The face is drooping on one side. The right arm drifts down when she lifts it. The words come out slurred, and the last time anyone saw her normal was 90 minutes ago. This is a stroke, and the clock is already running. Every instinct says give the clot-busting drug, now. But do that first, and you might kill her. What comes first? Here is your question. A client arrives with sudden facial droop, right arm weakness and slurred speech. The last known well time was 90 minutes ago. Which action is the priority? A. Obtain a stat non-contrast CT of the head. B. Administer the clot-busting drug TPA immediately. C. Give an antihypertensive to lower the blood pressure. D. Give aspirin now. Pause right now and commit. 3, 2, 1. The answer is A. The non-contrast CT of the head, first. Because there are two kinds of stroke, and they look identical at the bedside. If it is a clot, the clot-buster can save the brain. But if it is a bleed, that same drug is lethal. The CT is the only thing that tells you which one you are dealing with, and until you know, you cannot give the drug. Here is why the clock matters. A clot lodges in an artery feeding the brain, and downstream the tissue is starved. At the center, the core, neurons die within minutes. But around it is the penumbra, tissue that is stunned but still alive, and still savable, if you restore the blood flow fast. That is what the clot-buster does. Every minute you wait, the core grows and the penumbra shrinks. Time, quite literally, is brain. So the whole decision turns on one split. About 7 in 8 strokes are ischemic, a clot blocking a vessel, and there, the clot-buster given in the window can reopen it. But about 1 in 8 are hemorrhagic, a vessel that has ruptured and is bleeding into the brain. Give a clot-buster to that patient, and you turn a bleed into a catastrophe. You cannot tell them apart by looking. The CT can. That is why it comes first. So here is the order of operations. First, scan. A stat non-contrast CT, to rule out a bleed before any drug. Second, if it is ischemic and within the window, treat the clot with the clot-buster or a thrombectomy, checking the last known well time and the criteria. Third, protect the brain. Check the glucose. Keep the patient nothing by mouth until a swallow screen, and do not over-lower the blood pressure. Here is the rule to carry out of this. In an acute stroke, the non-contrast CT comes first. It tells you clot or bleed, and the clot-busting drug is only safe once a bleed has been ruled out. Fast, but in that order. So how do you spot a stroke? Use B. Fast. B. Balance, a sudden loss of it. E. Eyes, sudden vision loss. F. Face, a droop on one side. A. Arm, one drifting down. S. Speech, slurred or gone. And T. Time, the most important letter. The last time the patient was known to be well. A sudden, focal, one-sided deficit is a stroke until proven otherwise, and that last known well time decides everything that follows. 2 steps, and the order is everything. The CT does not treat the stroke, it tells you which stroke you have, clot or bleed. The clot-buster is what actually treats an ischemic stroke, dissolving the clot, but it must never go in before the CT. Give it to a bleed, and you kill the patient. So the scan first, always, and the drug only once the scan has cleared it. Speed matters, but not at the cost of that sequence. Now 2 instincts that make a stroke worse. First, giving the clot-buster before the scan. The pressure to act fast is real, but if it is a bleed, that drug is fatal. Scan first. Second, dropping the blood pressure. In an ischemic stroke, a high pressure is what is pushing blood past the clot to the tissue still hanging on. Lower it too fast, and you starve that tissue. You allow a permissive, higher pressure, and only treat it above strict thresholds. 2 to lock in. To recognize it, be fast. Balance, eyes, face, arms, speech, and time. And for the order, scan before the clot-buster. C. CT first. W. Window, check the last known well. B. Bleed ruled out. D. Then the drug. See a sudden one-sided deficit, note the time, and get the CT before anyone reaches for T. Now the wrong answers. B. Give the TPA immediately. Time is brain, so the urge is strong. But if this is a bleed, that drug is lethal. The CT comes first, every time. That is the trap. C. Lower the blood pressure. An ischemic brain needs that perfusion. Dropping the pressure starves the tissue you are trying to save. And D. Aspirin now. Aspirin is for ischemic stroke, but not before a bleed is excluded, and not when the clot-buster is still on the table. Tie it together. Your cues: a facial droop, an arm drifting, slurred speech, a last known well time of 90 minutes, sudden and one-sided. Your action: a stat non-contrast CT first, then, if it is ischemic and in the window, the clot-buster or thrombectomy, with a glucose check, nothing by mouth, and a permissive blood pressure. And the outcomes you are steering toward: a bleed ruled out, the clot treated in time, the deficit reversed or limited, and the brain protected. Now test yourself. Same face droop, same arm weakness, still within the window. But the CT comes back, and it shows blood. Do you give the clot-buster? No. In a bleed, that drug is catastrophic. This is a hemorrhagic stroke. Stop and reverse any blood thinner, control the blood pressure carefully, and get neurosurgery involved. Same symptoms, opposite treatment. The CT is exactly why you scanned before you dosed. One more: the CT confirms an ischemic stroke, and the blood pressure is 190/100. Someone wants to bring it down fast, do you? No. That high pressure is pushing blood past the clot to the tissue still hanging on. Drop it too fast, and you kill the penumbra. You let it ride, permissively, and only treat it above the threshold for the treatment you are giving. The urge to normalize the number is the trap. One last patient. Facial droop, one-sided weakness, confused, and she is a diabetic on insulin. It looks exactly like a stroke. Rush her to the CT? Check the glucose first. It is 38. Hypoglycemia can mimic a stroke perfectly, weakness on one side and all, and it reverses in minutes. Give the dextrose, and watch the deficit melt away. Every suspected stroke gets a glucose check, because this mimic is instantly fixable, and you do not want to miss it. And here it is, the whole topic on one screen. The pathway, the priority order, the rule, and the numbers that mattered. Screenshot this now, and you have got the entire case in your pocket. Then let's meet the next patient. Next episode. Crushing chest pain, radiating to the jaw. The patient is pale, sweating, and clutching the chest. The monitor shows the telltale ST elevation. This is a heart attack in progress, and there is one drug you give in the very first minutes, and one clock you are racing to the cath lab. What are they? That is episode 10.